So today we're going to talk about screening for Down syndrome. We're lucky enough to have Jill Harrison with us today, who's from the Society of Radiographers. I'm just going to give you a quick introduction to Positive About Down syndrome in case you're new to us, and then I'll hand over to Jill. So apologies if you've come to all of our webinars and you know all about us, but these are for the newcomers. That Positive About Down syndrome is under the umbrella of the national organisation Down Syndrome UK. We've been going just over 6 years at the moment, so we're in our infancy, I guess, but we've packed a lot into those 6 years. We've done a little bit of research. We've had those published in our results published in the British Journal of Midwifery. But we're also, Nicola and I are also part of the National Down Syndrome Policy Group that have been involved in supporting Dr. Liam Fox in the introduction of the Down Syndrome Act. So we do quite a lot of things within the Down syndrome community. So as a parent-led charity, we consider ourselves to be the experts through experience. We know what a good maternity experience should look like, and we're empowering women to make sure that they know what a good experience looks like as well. But we're also working together with local hospitals and universities. We provide our resources for free, and we do more extended training sessions like this to empower professionals to make sure they're delivering that, excellent service. So we believe that every woman has a right to that good maternity experience, that they're not exposed to negative discrimination or poor language associated with Down syndrome. So that's one of our motivating factors. You can see just quickly from this timeline how things have changed over the last 100 years or so. The life expectancy now for people with Down syndrome is 60 plus years. Points of note, I guess, are the Abortion Act in 1967, where still the part of that Abortion Act is that you can terminate a pregnancy up to term if Down syndrome is confirmed, because I guess in 1967 Down syndrome was still considered a severely disabling condition, but you might argue that actually isn't, that part of the Abortion Act is not relevant in the 21st century. Heidi Crowther is a young lady that's taken that part of the Abortion Act to court. It's in the appeal at the moment. So in terms of screening, ultrasound was brought into antenatal care in the 1980s, and first routine screening for Down syndrome in the NHS around 1990, but I'm sure Jill will tell us a bit more about that. So you know that Down syndrome can be screened for. The NIPT, the non-invasive prenatal test, came into the NHS a couple of years ago in England and earlier in Wales. And there was a lot of controversy at the start of bringing that in, that the accuracy rate was well below the figures they claimed. They claimed it to be 99% accurate for detecting Down syndrome, which isn't actually the case, but it's now rolled out into the NHS. One thing I wanted to point out is that previously, until recently, there wasn't an antenatal care pathway if you wanted to continue your pregnancy of if Down syndrome was suspected or detected. There was a really good care pathway if you wanted to terminate your pregnancy, but now there is an antenatal care pathway for continuing your pregnancy, which we've been working on with Professor Baskey from St George's Hospital in London, together with the Down Syndrome Research Foundation, which we do encourage all hospitals to have this part of their routine guidelines. It's not mandatory, but hopefully the Down Syndrome Act might help with that. But so take a look. It's making a really big difference to the women, but also it has improved outcomes as well. But I can send you a link to that. Just let me know. So just a little bit about language in talking about screening results. Risk is not, recommended anymore. Obviously, I'm sure you know this already, that risk is associated with danger and peril and a terrible thing happening, and chance or words similar to chance are recommended when talking about screening. Abnormality, problem, disorder. I've kind of put these in front of my son Billy. Is an abnormality? No, he's a boy. Is he a problem? He's a bit of a problem. He's a teenager. Is he a disorder? No, he has a condition called Down syndrome. He has a chromosomal difference. But so you're not talking about breaking news or breaking bad news or breaking good news or difficult news. You're sharing unexpected news. One of the most important things that we like to tell maternity professionals is, or well, everybody really, always use person first language. They are people with Down syndrome. They're not Down's babies or, you know, Down's kids, because our community have said that that kind of dehumanizes their baby. So do think about using person first language when talking about Down syndrome. In terms of the support that we're able to help, we have great expectations for pregnant women, but we also have a dad's group where they can share their you know, any kind of worries or concerns that they have, whether they've decided to continue their pregnancy or not, or whether they're, you know, had a definitive diagnosis or not. They're welcome in there, and we have experts on hand who are also parents of people with Down syndrome. So I've tried to make that brief so that I haven't cut any of Jill's talk. So I'm going to hand over now to Jill. I'm going to stop sharing so that she can take it up from here, and she's going to tell us about the sonographer's view from antenatal screening. Over to you, Jill.
Start by unmuting, haven't I? Let's go. Just bear with me for a minute while I share this. And
looking good.
Okay, great. So thanks everyone, and thanks for inviting me to talk today about the sonographer's view of antenatal screening. What I wanted to do, and this is where my thing won't move on, here we go. I want to just explain a little bit about the sonographer's role in antenatal screening. I'll talk briefly about the screening scans. I know most of you will know about this, but also some of the nuances and difficulties and challenges that sonographers face when they're doing antenatal screening scans. So I'll start off really, I'm just going to move, I'm going to try and get rid of pictures, there we go. So the sonographer's role initially is to undertake the scan, and they undertake a wide range of scans during pregnancy. That's from early pregnancy, looking for potential miscarriage, ectopic pregnancy, molar pregnancy, or looking to see that there's an ongoing pregnancy. They then undertake the 2 screening scans that everybody's offered during their pregnancy. But they also undertake quite a range of monitoring scans. So that might be if there's been a condition found, following up that case throughout the pregnancy, making sure that the pregnancy is progressing and there's no further complications. Looking at the fetal growth, particularly in the higher risk pregnancies with diabetes, maternal heart disease, maternal blood pressure issues. But also when you as midwives find something and you think, actually, I'm not sure, you know, how well this baby's growing or which way around it is, that kind of thing. We also look a lot at the blood flow to the fetus and also to the uterus. So as well as undertaking the scans, while we're doing that, we have to start to interpret it and make sense of the appearances that we're seeing during the scan. And then we have to analyse what we're seeing and think about what does that actually mean. So all this is while we're doing the scan and trying to talk to parents at the same time. And sometimes there's children in the room as well wanting to, you know, to understand what's going on or to play with dad's phone quite often. So we might be looking at something and thinking, actually, right, I've seen something here. What does that mean? What else do I need to look at? What are the implications for the pregnancy? And then also thinking about how am I going to write this in a report? So at the end of the scan, we have to write a report that's meaningful for the referrer. So that might be you or an obstetrician or whoever's referred that woman for the scan. But we also have to make sure that the parents can understand what we've written and make it relevant to them. And that's really the crucial part of the role, is actually explaining what we've seen to parents at the end of the scan. And we have to do that in real time. And I would say that's probably one of the most challenging parts of the sonographer's role, apart from the fact that babies don't keep still. So there are the 2 screening scans in pregnancy. And the first one is the combined screening test. offered to everybody between 11 weeks and 2 days and 14 weeks and 1 day. That's when the crown rump length has to be between a very specific range of measurements, so 48 to 84 millimetres. So we've got maternal factors, maternal age, a crown rump length and nuchal translucency measurement that we do with ultrasound. And then we've got the 2 biochemistry tests. So we've got the pregnancy associated plasma protein A and beta-HCG. So what I wanted to do really then was talk a little bit about how measurement accuracy is so important when it comes to combined screening. If we get this wrong, the outcomes of the test could be inaccurate, and that then can lead to quite severe consequences for decision-making processes and potential pregnancy outcomes. So what I've done here is put 2 babies. I think actually it's the same baby, slightly different positions. And this one you can see is quite curled. This one is in a much more relaxed position. If we measured, this one has been measured and you can see the orange line. If we measured this one, you can see there's a gap there. So actually this would be measured at a slightly different angle, probably about there. When you compare the 2, you can see that there's almost half a centimetre difference between the 2 image measurements. When you work that out in terms of crown rump length versus gestational age, you've got between 12 plus 6 weeks and 13 plus 1 weeks. 2 days difference is an error that we can't afford to take. Then we have to think about the combined test with the nuchal translucency. And we have to be accurate within 0.1 of a millimetre, which is really quite challenging, particularly with complicated pregnancies where the baby's in a difficult position, or if we've got high body mass index, or sometimes with scar tissue, if someone's had cesarean sections or any previous surgery, it can be really difficult to get this accurately. So what we're looking at is this tiny little gap here, fluid at the back of the fetal neck. Now, you can see this measurement is 1.4 millimetres and this one is 1.6 millimetres. So we've got slight inaccuracy here, or error between the 2 measurements of the crown rump length, and then we've got 0.2 millimetre difference with the nuchal translucency measurement. So that can make a difference when you put them together between the 14th and the 19th percentile. Now you're probably thinking, well, actually that really doesn't matter because it's still within that normal percentile range. And I've got another example here for you, 1.4 versus 1.6 millimetres. This one is on the 50th centile. This one is on the 25th centile. Again, not going to make a massive difference if all the blood results are within the normal percentile range as well. So it will depend on all the other results as well. What I've then done is taken this one with a nuchal translucency of 1.8 and the results are on the 75th centile. 1.9 takes it to the 95th centile. And these aren't the proper test results because normally you would get all the blood results and all the maternal factors included. But you can see what a difference 0.1 of a millimetre makes at that higher or lower end of the percentile range. So if you have a woman who is, say, 39, 0.1 of a millimetre will make a massive difference compared to someone maybe who's 29. So these are really important factors to consider when you're thinking about what sonographers need to be doing when they're screening. So having distractions in the room can really impact on their ability to get this right. The next scan we do is the 20-week scan. And this is where we're looking for 11 physical conditions. And this is usually between about 18 to 21 weeks. These are the conditions that we look for. Now, anencephaly, where there's no fetal skull, we should be able to detect that in about 98–99% of cases because it's usually, and certainly if you see it at 20 weeks, it's really obvious. It should be picked up at the first scan. in most cases. But then you come down to sort of congenital diaphragmatic hernia, and it's important as midwives for you to understand that sometimes these things won't be seen on the scan. And I know I've been told I've missed something by a midwife once. It was, oh, you've missed this. I had sleepless nights thinking how awful I was and how I should give up sonography. But actually, it wasn't something that would be detectable on ultrasound. So it's important to know that something like a congenital diaphragmatic hernia sometimes don't develop till later in pregnancy. Sometimes they'll be transient. So you may get this hernia where the stomach comes up into the lung, into the thorax, and you might see it. If it's in the thorax at the time of the scan, you will see it. If it's gone back down into the abdomen, you won't see that, and you won't necessarily see the defect in the abdominal wall, in the diaphragm itself. So it's important to understand that not everything can be seen on a scan. These are the things we look for during the scan. So we've got the fetal head, we do a measurement of the head, we look at the structures of the fetal brain, we check the fetal face and the upper lip, the nostrils, the chin. One thing we can't see very well is the palate, because the palate goes backwards, so we can't always detect cleft palate on its own if it's isolated. Then we measure the femur length, we look to make sure all the long bones are present. We look at the fetal abdominal circumference. In this sort of case, we'd be looking to make sure the stomach is present, and an absent stomach would just start us to think, okay, what else could this be? Is it just empty, or is it going to fill up during the scan? Is there a swallowing difficulty there, maybe esophageal atresia? Do I need to look at the fluid around baby? So there's all these thought processes going on when you're actually doing the scan. And then we look at the spine in 3 dimensions. So those are the key images we have to take. We do look at a lot more in most cases during the scan, but those are the images that we need to take. Dynamically, we look at the fetal heart as well, and that is really, really complex. Some of the subtle changes in the fetal heart are very, very difficult to see, and I'll show you why in a moment. As well as all the structures of the fetus, we also look to make sure that it's growing as expected for that stage of pregnancy. And that's linked to the dating that we do at the first trimester scan. So we wouldn't redate a pregnancy at any point in the second trimester. We would then say the growth is as expected or higher or lower percentile. We also look at the placenta. And in this case, you can see the placenta is on the posterior wall, but it's actually very, very close to the internal os, which is here. So in this case, we'd rescan at 32 weeks to see that that has moved up out of the way. We look at the life course, so we check to make sure the fluid around the baby is okay. We also look at the uterus and the adnexa and the ovaries to make sure there's no masses such as fibroids or ovarian cysts. I've popped this one in just because I like putting some colour images in, but this is the cervix here. That's the internal os, and you can see there's a vessel overlying the internal os. The placenta is very low lying, and that's quite typical of a vasa previa. Now, this isn't part of the screening scan. It's not even part of any screening process, but if we see something like that, obviously we want to be able to alert you to that, so that you can then think about management of that pregnancy. We do guide invasive procedures as well. So this is a needle going into the amniotic fluid for an amniocentesis. This way of doing an amniocentesis is much, much better than when I first used to start scanning, where somebody would just literally put a needle in and see where it was. Sometimes I got asked to look for a needle, but not always. This way we can be really sure that we're not going to be piercing the placenta, but also that the baby is well out of the way. So it's a really good advantage of a real-time scan. Next are some of the challenges with pregnancy scanning. So body mass index makes a big difference. In this case, you can see superficial tissue before we get to the placenta. So the sound is scattered, it's reflected, it's all over before we can actually get down to the fetus. So often the image quality is not as good. It's not because we don't try, it's because the sound actually has to get through a lot of tissue before we can get to the structures we need to see. In this case, there's much less superficial tissue, so we get a much clearer view of the pregnancy. Then we think about the fluid around the baby. So in a case where there's very little fluid around the pregnancy, we find it really hard to see things clearly. You can see here there's a little bit of black around the spine, so we can see the skin surface really nicely. If there's a reduction in amniotic fluid, it's much more difficult because we use that as a window to look through. So if there is a problem in terms of a reduced amniotic fluid level, or someone's had a spontaneous, I've forgotten the word, can't think of the word, but you'll know it better than I will, rupture of membranes, then it might be more difficult for us to be able to see the kidneys clearly, or the some of the structures within the fetus. And then we also have fetal lie. This is a beautiful position for the fetal head. We can see the detail of the fetal brain really, really well there. This one should never have been measured, but that baby is looking up towards the maternal abdomen. And if the head's down in the pelvis, we can't get around the maternal pelvic bones to get that view. So we will have to get that woman back or send them for a walk. And sometimes we just can't get what we need, particularly later on in pregnancy if the head is really low down in the pelvis. So what are some of the challenges for sonographers? There are many challenges, but some of them are clinically related, and one of them is the time constraints. We have 15 to 20 minutes. It should be 20 minutes for a first trimester scan, 30 minutes for a second trimester scan. What I'm finding is people are coming to me as working for the professional body saying, what do we do? How do we fight this? People are telling us we need to do more scans in less time. Now, the more scans we do in less time, the more likely we are to make errors, and that has implications for pregnancy management. So there are really challenging issues with time constraints. And there is a lot to get through in a 20-minute or a 30-minute scan. Not only do we do the scan, we have to make sure that the consent is valid and informed, because I know that you as midwives don't always have enough time to explain everything, and parents don't take everything in the first time or the second time or even the third time round sometimes with such complex information about screening. So as well as the scan, we then have to do write the report and discuss the findings. But also the scans are really complex. And over the years, the equipment's got better, so the complexity of the scans has got more. And you might wonder why I've stuck a picture of my slightly nicer thumbnail in there. That's to just show you that the thumb, the size of the fetal heart at 20 weeks is about the size of your thumbnail. So we are looking at a structure that is the size of your thumbnail and looking to see if there's 4 chambers, if the outflow tracts coming from there are normally positioned, or if they're in a slightly unusual position. There's lots of things for us to look at there and think about in very, very small structures. We've also got quite a lot of challenges with expectations from parents about what we can and can't do with a scan. And that some of that is because the information is given to them, but they also know about private scan clinics and what you can see there. And yes, you can get beautiful 4D scan pictures, but that's not really important in the screening scan, where we are actually looking to see whether the structures are normal or there's any changes in the structures from that normal expectation of at a specific gestational age. So we can't do everything. We can't do sexing scans as well as, but we can look at the sex, but we don't have the time to be writing down the sex in an envelope, sealing that up, you know, and doing all the things that you can do in a private scan, because the private scans generally don't look in the same at the same level of detail that we do for the screening scans. And then we've also got the challenges when we find something that we're not expecting. We don't have time to prepare ourselves for explaining that to someone. So we're literally scanning. Parents are watching our faces. They know when something's different. They know when the sonographer's suddenly gone from being very chatty to concentrating really hard. They're asking questions because they're suddenly anxious about why the sonographer's not talking to them. The sonographer's trying to work out what's going on, but also sometimes we don't really know what the implications are for that pregnancy. So there's a lot going on there, and it's sometimes quite challenging to be able to explain that clearly without jargon to somebody who is suddenly then very anxious at our, looking at our body language. And that can then impact on the time, because we have to spend as long as we need with someone when we've given them unexpected information. And then we've got a waiting room full of people outside, all with full bladders usually. So I'm going to talk very briefly about communication. It's really difficult to get the wording in the most appropriate way, and particularly for people who've worked in ultrasound for a long time. When I trained, we were told about lemon and banana signs when we were looking at the fetal head for signs of potential spina bifida. So this would have been called the banana sign. Now, we can't say that to parents, but I have known in the past people have put lemon banana sign in a report and given it to parents, and then parents are saying, well, why has my baby got a banana brain? So it's really important that we change with the times, we move on, and we keep learning about communication. So we have got some consensus guidelines now, which were published quite recently. And again, some of this links with what Lucienne was saying, expected rather than normal. And I still sometimes have to stop myself halfway through because I've been using some terminology for many years. But it's about knowing that terminology's changed. If you get it wrong, accepting that that's not the way it is anymore, apologising and moving on and learn from that. So those are just some of the terms that are in there. So some of the other challenges in terms of sonography, we have a workforce shortage, the same as with most other areas of healthcare, and I know midwifery is probably as bad, if not worse, in terms of workforce shortage. But sonographers sometimes work across different directorates. So they might be in obstetrics some of the time, but they might also be doing non-obstetric work. And there is a massive national backlog of non-obstetric ultrasound, to the point that the government are actually getting worried about it. We've got new entry routes into ultrasound. So we've got healthcare professionals, so midwives, radiographers, nurses who do ultrasound, and they are statutory registered. But we now have non-healthcare professionals coming in to do postgraduate ultrasound who aren't able to get statutory registration. But we also have two BSc routes that have been opened up. One is a traditional route for people coming to do like midwifery or radiography, so they can do ultrasound. And we've just got our first apprenticeship that started in March this year. So there's a lot more people coming into ultrasound, and we've got a career framework to work with that. But there are limited progression opportunities in obstetrics, particularly. And I think this is one of the real problems we've got in trying to keep the workforce in obstetrics. Partly they don't necessarily feel valued, but they're not seeing any opportunities for progression. In a survey in 2021, 19% of people who were consultant sonographers were in head and neck ultrasound. Less than 3% were in obstetrics, and not one of those was a radiographer background. So these were nurses or midwives who were extending their role. And we've also got a morale issue, and I'm sure I don't need to tell you about this. It's happening across health service. But a survey published last year that was led by Emily Skelton showed that more than 90% of sonographers met burnout thresholds, and 73.9% were talking about either leaving their role altogether as a sonographer or changing their role. And most of them, by changing their role, meant getting out of obstetrics and going into general medical ultrasound. So this is another real challenge for our workforce, and we need to try and get them to want to stay in obstetrics. So what we're doing is working with the fetal anomaly screening programme, with antenatal results and choices, and we have spoken to NHS England to look at what we can do to try and increase workforce numbers, make sonography an attractive career in obstetrics, and how can we retain sonographers in obstetrics? Because people start out being really excited when they start as sonographers, but then over time they become jaded, and we need to make sure that actually they have really good opportunities to progress. They have opportunities to improve the service and promote the role, but also we've got to think about enhancing team working in obstetrics for sonographers. Because what we found during the pandemic is decisions were being made about antenatal ultrasound services without consulting sonographers. There was a lot of abuse going on. We've had all sorts of terrible things happen to sonographers during the pandemic, and I'm sure that's happened to midwives and obstetricians as well, and lots of other healthcare professionals. But when they don't feel part of a team in the maternity setting, that makes it even harder. So we need to look at that. So we're putting together a guidance document to really sort of give people tips on how to make the services better. Hopefully that will be out sometime in the next few months. The other issue is that sonography is not regulated. So I am regulated as a radiographer. The new entry, direct entry routes into sonography have no potential route for regulation at a statutory level. We've got the voluntary register, the Register of Clinical Technologists, which is accredited by the Professional Standards Authority, but that is voluntary, so we don't necessarily have to be registered as a sonographer and practice. The NHS tend to want people to be registered on the RCT or the HCPC, NMC, GMC register, but private practice is not always the same. Another challenge we've got then is two-tier service, and it's not as obvious in obstetrics because we're not usually requesting ionising radiation or prescribing, but people who don't have statutory regulation aren't able to apply for the apprenticeship in advanced clinical practice, so they're being disadvantaged in that aspect of their career development. And then this is probably the elephant in the room, really. There's a massive difference between some private baby scan clinics and others. And I think it's important for you to understand what's going on out there, because some of this is a bit like the Wild West. In the NHS, our staff are usually qualified to a very high level. For fetal anomaly screening programme scans, there are minimum requirements of education, and they have to be case accredited programmes or equivalent. So our BSc qualified sonographers won't be able to do the fetal anomaly screening scans until they've gone through a period of preceptorship, capability development, and are at the next career level. In private practice, the scans can be done by anybody. They might be done by sonographers who work extra hours at weekends, evenings, or work for that private clinic. But equally, I know of clinics where someone's had half a day of training using a machine by the application specialist and have no qualifications whatsoever. There are others who've had 2 days training. Now, that's not good enough, in my view, to be able to look at pregnancy scans properly. We then have diagnostic and screening scans that we do in the NHS, where we are looking to see if everything looks normal for that stage of the pregnancy. And if it's not, we're able to manage that and get appropriate support for the family. Sylvania scans are not looking to see if there's anything unusual. They are looking at, here's your baby, there's a nice picture, or look at that arm, or it's waving at you. And there's a big difference with some of these baby scan clinics. Some will offer a diagnostic scan and some basic assessment. Some won't be offering that at all. The complexity of what we do in the NHS is very different. there is a massive difference in variation in private baby scan clinics. So we've worked with the Care Quality Commission, and there's a link on there to some of the guidance that we've given to parents and to you as healthcare professionals if you're advising parents on where to go for a baby scan.